Okay, it's 11:01, so we'll get started. So good morning, everyone, and thank you so much for joining our virtual STEGH Talks session. Just a few quick things to note before we begin. In an aim to reduce background noise, we're going to be muting everyone except Libby and Dr. Cieslak. If you have any questions during the presentation, please type them into the chat field and we will try to answer as many questions as we can during the Q&A. This session will be recorded and shared at a later date on our Facebook and YouTube channel. On behalf of the STEGH Foundation and the hospital, we welcome and thank you for joining us for today's special STEGH Talks virtual session in recognition of Stroke Awareness Month. It is my absolute pleasure to introduce Libby McConnell and Dr. Martin Cieslak from STEGH. Libby graduated from Ryerson University BSCN program in 2016 and then took a full-time position in a small community hospital on the medical, surgical, and obstetrical unit in Georgian Bay. Libby moved to this community in 2019 and started working in STEGH's emergency department and soon after transitioned to the role of clinical educator. She always has been passionate about leadership, education, and motivating others. Libby completed her Master's of Nursing, Leadership, and Professional Nursing Practice in 2021 and is now the manager of the Integrated Stroke Unit in St. Thomas, as well as the District Stroke Coordinator for Elgin, Oxford, and Norfolk. Dr. Martin Cieslak attended medical school at University College Cork, Ireland, then completed his internal medicine residency at Western University in 2013, followed by a critical care medicine fellowship at Western University in 2015. Dr. Cieslak has been at STEGH since 2015 and is the chief and medical director for the Department of Hospitalist Medicine and physician lead for St. Thomas Stroke Program. Thank you so much for joining us today, Libby and Dr. Cieslak. Take it away.
Thank you for having us.
Thanks so much, Kenzie. Can you just give a thumbs up that you can hear me and Martin okay?
Absolutely.
Perfect. So thanks again, Kenzie, for the introduction. Dr. Cieslak and I are really looking forward to sharing this presentation with everybody today. Within the following slides, we really want to work together to highlight how you can recognize a stroke, what the stroke survivor's journey may encompass, and how the stroke unit at STEGH operates. We are happy to take any questions at the end. And I'm going to now turn it over to Dr. Cieslak.
Hi, thanks, Libby. Can I have next slide, please? So firstly, I want to bring everybody on board. I firstly welcome and thank you for having Libby and myself today to give this talk. I want to start our journey off with a little bit of a definition of what a stroke is. So essentially a stroke is any time there is an obstruction of the blood flow up to the brain, resulting in some level of injury to our brain cells. The effects of a stroke will very much depend on where the injury is occurring, and that will manifest itself with how a person will present and what kind of symptoms they will have. Broadly speaking, there are three different kind of classifications of stroke, and there's subcategories between some of these other classifications. Firstly, we have the biggest group, which is the ischemic stroke group, which is typically the result of a blockage of blood flow to a part of the brain. Now, that blockage can be a result of problems with the smallest blood vessels of the brain. It can be a result of a clot traveling from one of the arteries into the brain, or what we see in about 20 to 40% of strokes, a result of a clot coming from the heart, traveling up to the brain, causing a blockage. The other kind of broad stroke that we have is what we refer to as a hemorrhagic stroke, which is when an artery breaks open and we have bleeding into the brain. These types of strokes can be of varying severity, depending on how much blood comes out, and can be something as very innocuous as a very microscopic bleed, which we only recognize on doing CTs, and the patient may be completely asymptomatic, or they can be very catastrophic bleeds, resulting in much higher levels of surgical care involvement than we're able to provide here at St. Thomas. Now, underpinning all of these are what we refer to as transient ischemic attacks. These are typically caused by either a small clots or very small bleeds, and result in a brief presentation of symptoms. Now, by definition, a transient ischemic attack has a complete resolution of symptoms under 24 hours. But most patients will end up having symptoms for less than an hour and even a few minutes. We treat TIAs very sorry, computer issues. We treat TIAs very seriously because they may be very well a harbinger of worse things to come. And so they're very important for us to recognize when patients have them and institute investigations to try to figure out what's going on. Next slide, please. So broadly speaking, what are the signs of a stroke? Now, if there's one thing that you get out of this talk is it should be this little brief acronym FAST. Is your face drooping? Are you able to raise your arms up? Is your speech slurred or jumbled? And if so, it's time to call 911. FAST is sort of the broad stroke presentation of many of our strokes, and ones that we can clearly recognize and have can have a very significant impact on the quality of life on a person. However, as mentioned at the very beginning, depending on where the injury from a stroke occurred, you can have a very broad range of symptoms occurring. So if you have a stroke that occurs in the posterior part of the brain, where our vision centers are, you may experience visual changes. If you have a stroke in parts of the brain that are responsible for sensations, you may experience some form of numbness on one side of the body or the other. Now, the one important thing to recognize is that the brain is cross-wired, meaning for the majority of strokes, an insult to the right side of the brain results in left-sided deficit and vice versa, which typically means that most people, when they come in with a stroke, will only have symptoms on one side of the body and not the other. There are a few little exceptions in the posterior part of the brain where the cross signaling is occurring, and sometimes you can have bilateral symptomatology, but those are fairly rare strokes. Now, if you are experiencing any signs of stroke, the most important thing to do is actually call 911, not to drive yourself to the hospital. And that's because stroke care throughout the region is siloed into different institutions and organizations, and not every hospital is able to provide the best quality of care and most appropriate care for a person who's having stroke. The EMS workers are able to recognize signs and symptoms and redirect you to the most appropriate hospital for the stroke care that you're going to need. Next slide, please. So, taking a step back from before having a stroke, what are the things that we can do to prevent having a stroke? Well, from a statistical perspective, 9 out of 10 Canadians have at least one risk factors for stroke. And this can, as you see on the slide here, be anything from an unhealthy diet, physical inactivity, excessive stress and smoking, hypertension, diabetes. All these things are very common risk factors that we see for stroke. Essentially, to break things down, anything that can increase the likelihood of a blood vessel breaking or a blood vessel being forming a clot or narrowing can lead to a stroke or stroke-like presentation. Next slide, please. So what happens if you do find yourself having or experiencing these stroke symptoms? Well, you've obviously attended this talk and have called 911. EMS will then arrive at your home or place of work where you're having your event, and they will follow an algorithm that they have based on the severity of your symptoms, take you to the most appropriate closest hospital. In our region, this typically means either coming to St. Thomas or being directly diverted to the University Hospital in London. The differences between the two hospitals are that for certain types of strokes, particularly ones that are detected very early after onset of symptoms, we're able to provide some curative therapies. These curative therapies can include TPA, which is essentially a clot busting drug, breaks up a clot that's happened there. And for other larger clots, we can actually retrieve that clot with an endovascular therapy called an endovascular thrombectomy with neuroradiologists in London, threading a little tiny catheter up into the brain to where the clot is and literally pulling it out. And so this is one of the most important parts about why you need to call 911 when you're having stroke symptoms, because in the first few hours, some of these therapies are accessible if you have the right type of stroke. Now, obviously, hemorrhagic strokes do not fall into this category because you're bleeding. We can provide treatments to kind of help stop bleeding. And depending on the severity of the stroke that you may have on the first CAT scan, you will either be directed to ongoing care in St. Thomas or redirected up to the neurosurgical teams in London, where further care will be provided. Next slide, please. So if you've had a stroke and you're not a candidate for any of these therapies, because either it was a stroke that's too small or the timeline between when you first started experiencing symptoms and when we were able to see you in the hospital setting, it was just too long or too elapsed, you'll end up being admitted to one of our stroke units in the region at St. Thomas. This is our integrated stroke unit. And about 2/3 of people who are presenting with stroke-like symptoms end up getting admitted to a hospital. The timeline of recovery for these people is variable. As you can imagine, the severity of stroke and other risk factors that you have will determine how quickly your body will recover and if it will recover fully or not. When you're admitted to hospital, we will start the process of trying to identify what caused the stroke, where the damage had occurred, and then what are the subsequent effects that it may be causing for you. And then we get our allied health teams involved to start the recovery process. There's a lot of initial testing that happens because we very firmly want to determine what caused the stroke, particularly if it's an ischemic stroke, because we can mitigate risk for further strokes with appropriate medical therapies and interventions. Next slide. After a period of time, if you haven't made your full recovery, and some people can make very quick recoveries after a stroke, and within 2-3 days time, they're ambulating and functioning independently. Some people, unfortunately, don't have that rapid response, particularly people who have very significant strokes, large strokes, or strokes that are involving a multitude of interconnected areas. Because it takes time for that brain to reorganize itself in a process called neuroplasticity. And so at that point in time, you'll be started off on your rehabilitation journey. And that can take anywhere from days to weeks to sometimes months and longer. Next slide, please. One of the most important processes that we have, like I said, is the TIA element, the transient ischemic attack, and many people in the emergency room and also in family practices will present to the doctor saying, "Oh, I've had this little spell the other day. I lost vision in an eye. Kind of a shadowing blackness came over one eye, and then it kind of resolved." And you don't really think much about it. It's just like, okay, maybe I had something in my eye or something else. And but for us, it's a very important thing. And for this reason, we set up our urgent TIA and secondary stroke prevention clinic. This clinic operates Monday through Friday. And we typically like to see patients with these transient or small stroke attacks within a 24-hour to 72-hour period. In the last year, we saw about 840 new patients who presented with some of these symptoms. And this is a nurse-led clinic with a internal medicine physician providing the physician support for this. And we do a very comprehensive stroke risk assessment. Some of our patients who are coming in with what we think is strokes or mini strokes may actually have an alternate diagnosis, migraine being a very common presentation of neurological symptoms that seem a little bizarre, but are not related to an ischemic event, a loss of blood flow for one reason to another. We also provide post-stroke follow-ups for people who've gone through our stroke unit and make sure that we bridge the gap between patient care from inpatient to the community stroke outreach teams. Okay, next slide.
All right, so I'm going to pick up from here. Thanks, Dr. Cieslak, for really outlining those broad processes involved in stroke care. So now that we're here, I'm going to bring us through stroke care at STEGH and what exactly that looks like. So at STEGH, we have an integrated stroke unit. It opened in 2016 and it consists of 10 beds. So out of those 10 beds, we have them separated into rehab beds and acute care beds. The reason being we're an integrated unit, which is a very valuable thing. So if a patient comes in, they're having that acute phase, that acute stroke care needs, they would stay on the same unit in the same bed as they transition throughout their entire stroke care journey. The integrated stroke unit, it's also called the ISU for short. It is located in the south building on the first floor, which is at the end of D wing on complex continuing care unit. We do have a very centralized workspace for the healthcare team. So if you are up on the unit, we've got a very large nursing station that overviews all of the patient rooms and different care areas. We also have a specialized rehab gym on the unit. This is huge because it allows stroke patients the opportunity to just go a few seconds down the hallway and they're already at their gym where they can participate in therapy throughout the day. In addition to that, we have an independent living suite, which is very unique to our organization. I will expand on this in the latter part of the presentation, but the purpose of the living suite is to give patients the opportunity to practice some of those tangible skills before they have to go home. So they would transition from their regular ward room into the living suite, maybe 72 hours before discharge, and really get the opportunity to practice cooking, cleaning, bed making, showering in an environment that really mimics a home environment. So we're really, really happy to have that on our unit. And then like Dr. Cieslak said, we've got our secondary stroke prevention clinic, which is crazy to believe we've seen 840 in the last year, but I can certainly believe that. So very high functioning clinic. Next slide. So the STEGH stroke team. So working together as a team is really how we work best in order to create support and foster our patients' unique goals. As Dr. Cieslak mentioned, everybody's stroke journey is slightly different. No two people are the same. So we really do work within this collaborative team approach to make sure we're meeting the needs of all of our patients. So on the stroke team, we have a unit clerk who is a really big integral part, helps with a lot of the administrative type duties. We've got physicians. We have two primary ones that are on the floor throughout the week and on weekends. We've got registered nurses and registered practical nurses who help with the day-to-day operations, tasks, delivering the orders that the physicians have put through. We have an occupational therapist, a physiotherapist, and therapy assistants. So again, a really crucial team that helps to put together the patient goals and work with the patient and families to make sure we're meeting those goals. We have a speech language pathologist and a communicative disorder specialist. So those are two disciplines that really help with any comprehensive and communication deficits that may have been suffered because of a stroke, which can be quite common. So those are very big assets to the team as well. We have a recreational therapist who helps to introduce some leisure-like activities. And then we always see on the unit our dietitian, our diabetic educator, social worker, pharmacy, lab, imaging, that's a big one, our prevention clinic, and then external community supports. Next slide. So just to outline the roles and responsibilities, as I mentioned, it's really important to know that the stroke care journey can look different for different people. And that's why everybody on the team plays their unique role, but they all come together to provide care for our stroke patients. The team provides both acute and rehab. That's what makes us integrated, and supports families and patients who have suffered a stroke on their journey. We really do involve ourselves in goal setting, planning recovery, whatever that may look like, providing physical care each and every day, providing education and support so that we can prevent future reoccurrences, coordinating care to make sure people are transitioning to the most appropriate place after they leave STEGH, strengthening confidence and comfort in helping people adapt and participate in activities and tasks while doing it in a new way, and then supporting social and emotional needs for all of our patients and their families. Next slide. So the benefits of stroke care, hard to fit this all into one, but at STEGH, we actually saw 254 patients last year. So on average, we're around 200. So it's climbed just a little bit there. But STEGH is, as Martin alluded to, it's a district stroke center, which is important to know. Because of that, there are special services like our stroke unit that we're able to offer within our own community. So for example, our integrated unit offers both of those rehab and acute services. So patients aren't having to leave the unit for rehab. They can stay right where they started and continue on with the same team. So that really leads into the consistency. When the patients start on our acute unit and they initially get admitted, because they stay with the same team in the same room, the team really gets to build strong relationships with the patients and get to know what are the goals that are important for that individual and how can we see that through from admission to discharge the entire time. Our living suite is certainly a benefit, allowing patients the opportunity to learn new skills, ask questions, make mistakes, learn new ways of doing things before they go to their own home setting. And our unit's physical layout, the rehab gym being close, our imaging department being close, it all supports a patient-centered care approach and really just optimizes the access that patients have while they're admitted on the unit. Next slide. So just to mention, all of the inpatient processes wouldn't always be possible if we didn't have that community support and that external support from different providers. So here on the stroke unit, there's a couple of key people that we connect with that are outside of STEGH. So the community stroke rehab team is a big one. They are referral based. So if you or someone you know is having a stroke, you can actually print off the application and refer yourself to this team. You can also have your family physician, emerged physician, or if you are on the stroke unit, a physician here can complete it as well. In addition, we really use the Southwestern Ontario Stroke Network. So they're a very broad, overarching collective group that collaborates to make sure all of the district stroke centers, which would be STEGH, are always following stroke best practices. We're up to date and we're making sure we have the education and support that we need for our patients and for our staff. Healthline is another option that's available to staff, patients, caregivers. It can be accessible online and it splits up resources that are available within communities and it's based on geography. So you can find specific supports if that's what you need post-stroke. LIN supports are also known as CCAC. They help to coordinate post-discharge as well. And another big one is our peer support program. So every single Wednesday, we have an ex-stroke patient that was a previous STEGH patient come in for 2 hours and he spent some time with our current patients just to really offer up that one-on-one support, help to address any concerns, fears, and just give his experience while learning on new experiences as well. And then finally, Heart and Stroke. A lot of the content from today, such as that FAST acronym, comes from Heart and Stroke, and they've got a ton of resources on prevention and recovery as well. Next slide. And just to highlight some recent improvements on the unit. So as I mentioned, due to some really generous donations in the community, we were able to renovate our living suite just this past winter. So we've seen huge value in doing that. And we continue to use that suite weekly at least. We've installed a team board that really helps patients know who are the people that are on board in their care, what do they look like, what are their names, and who works together, what are the faces behind the work that's going on. We've created a aphasia-friendly resource wall, and that's just a wall full of documents that really help speak to people that may have any communication or comprehensive type deficits because of their stroke. We are currently in the process of preparing and planning for stroke distinction. So stroke distinction is a very highly specialized quality improvement program. It is founded by Accreditation Canada and it works with Heart and Stroke. It allows us to really look at our current practices, figure out what are we doing well, what are some areas we can improve upon. So in November, the team here at STEGH will be going through that process, which is something that we're excited for as well. Our patient education passport is another improvement that we've recently just included. So every patient that comes to the stroke unit gets this very comprehensive book of education, and it follows them throughout their journey on the stroke unit. The nurses, the allied health, the different disciplines, they all carry the passport with the patient. They have a little backpack that it can go in, and we all make sure we're updating it so people feel well informed and know what their goals are and what kind of care is taking place. And then lastly, stroke prevention clinic process improvements. So just making sure the way we refer people and the way we receive referrals is working well. We're always looking at that as well. Next slide. So the second last thing I wanted to share here was a patient's journey. So thankfully, we really value our patient and family feedback. It's what helps us to improve and find areas to do improvements on. So on the right-hand side here, I do have a little quote from Steve. He was very happy to let me share this with everybody today. Steve suffered a very significant stroke. He was on our unit for quite a few months. He was under the age of 50. And because of the teamwork on the team and Steve's continued persistence and hard work, he was able to make it home with some supports from his daughter. He was always finding it helpful that staff were willing to problem solve and find solutions, find new ways of doing things that worked for him. And for his daughter, she really felt like the STEGH team on the integrated stroke unit became like family, which I could agree. We certainly miss him here, but happy to see him thriving in a better environment. And then on the left-hand side there, just a little reminder, stroke is a heavy topic. There's a lot to know, a lot that can go on, but stroke recovery very much is possible. And as Dr. Cieslak mentioned, recognizing those signs and calling 911 is the first kind of step of action that everybody can take as a takeaway today. Next slide. And then lastly, I find this presentation to be very timely. So thank you, Kenzie, for reaching out, because June is Stroke Awareness Month. So within STEGH, we've been doing activities with staff throughout the month just to really highlight the importance of being aware of stroke and what it means. And the biggest point on here is just remembering that FAST acronym. You never know when you yourself or a parent, a spouse, or a friend might experience some of the signs that you've learned about today, and it may be up to you to act. So just highlighting that importance of calling 911 and getting appropriate treatment. Next slide.
Okay, well, thank you, Libbie and Dr. Cieslak, for your awesome presentation on stroke. Now is the question and answer portion. So if anyone has any questions for either Libbie or Dr. Cieslak, please feel free to write them in the chat box and I will read them out, or please feel free to also unmute yourself and ask a question. I have no problem starting it off. So I'll ask, what are the risk factors for stroke, and what kinds of things can you do to reduce these factors?
So maybe I'll answer this one. I mean, risk factors for stroke are fairly broad, and I mostly pertain to risks of causing injury to our blood vessels. So blood vessels get injured through wear and tear. And so one of the easiest kind of risk factors that we can control from a wear and tear perspective is getting our blood pressure checked and making sure that we're not experiencing issues with high blood pressure. Blood vessels are simply put pipes, and if they experience too much wear and tear from a pressure perspective, they're more prone to break or to crack. If a blood vessel were to break, that's what we refer to as our hemorrhagic stroke. If a blood vessel were to start cracking, then that starts introducing some of the other risk factors that we have. So other major risk factors are things that will make those cracks more prominent and potentially cause turbulent flow around those cracks, and causing essentially a slow buildup of plaque in the blood vessels, which can then break off and cause problems. So things like diabetes, which cause inflammation of our blood vessels, things like very high cholesterol levels, which can just build up in those cracks, can cause issues with the buildup of plaque in those cracked blood vessels. And lastly, one of the major ones is smoking. Smoking can certainly introduce not just issues from the lungs perspective, but they cause a lot of inflammation, inflammatory changes in our arteries, resulting in a cascade of diabetes and high lipids becoming problematic. So what can we do And then, sorry, lastly, in terms of risk factor perspective, there's things that we can't control. So these are the things that we inherit from our parents, our genes, and predisposing kind of features. So if you have a family history of strokes in your family, it's very, very important that start looking towards modifying some of those other risk factors. So what can you do to prevent a stroke from happening? Well, number one is get a periodic checkup with your family doctor or your primary healthcare practitioner, having periodic assessments for diabetes, high blood pressure, and high cholesterol levels is, I think, very important risk factor modification. Number two is eliminating some of these toxin-induced injuries that we can do to our blood vessels. So number one, of course, being smoking. Alcohol can also play a role in this. So if you drink excessively, that can become a personal problem. And then lastly, just general healthy lifestyle and weight loss. All of this can help mitigate some of those other risk factors for our stroke patients and our pre-stroke patients.
Thank you so much,
Hope that
Dr.
answers the question.
Cieslak. It did for sure. If there's anyone else, please feel free to pop into the chat box. Another question. What kinds of problems occur after a stroke? What kinds of continuing things can someone deal with after this?
I can start, Dr. Cieslak, if you want to add. Okay, we won't fight over it. So Kenzie, it's a great question. On the stroke unit, I would say a lot of the time stroke deficits are different depending on the damage, the person, how long you waited, that sort of thing. But generalized weakness on one side, that seems to be a very common thing. So let's say you had damage on the left side of your brain, your right arm may remain very weak, tucked in, contracted, and it can be very hard to mobilize that. Speech and communication. So aphasia, like I mentioned, is a really big one. And that's where the regular communication and comprehension abilities that a person had pre-stroke have been impacted because of the damage. So they may be feeling like they are wanting to communicate things, but actually being able to do that certainly changes. And the other big one I would say is your ability for your intake. So your swallowing, sometimes that becomes impacted as well. And that is certainly a goal that we focus on a lot up here.
Thank you so much, Libbie.
I think that's a very good summary. There's a few other kind of little things that can occur as a consequence of a stroke for some of our patients. So one of the early complications that somebody can have after a stroke is something like a seizure. Because a part of the brain is being damaged, there's a significant release of neurotransmitters, the chemicals that help a brain function and connect one cell to the other, and sometimes that can lead to seizures. So we see that it's fairly rarely, but it's something that we keep an eye on. The other complications that can occur immediately after stroke is heart rhythm issues. Some patients may develop heart arrhythmias after a stroke, or they become the heart arrhythmias can become apparent, and some of these arrhythmias can be symptomatic. So people can feel short of breath, have experienced some chest pain. And for this reason, most of our patients end up wearing a Holter monitor on presentation to our stroke unit to help us monitor and see if there's any detection of these arrhythmias that can occur. The long-term during the stroke recovery, as Libbie alluded to, a lot of patients can have, persistent weakness. Sometimes this weakness doesn't quite resolve, and people can experience what we refer to as contractures, where that muscle, just because it's not working, it starts getting shorter, and that can result in pain. We send people not infrequently to Parkwood for Botox injections to help release the tension in those muscles to relieve pain symptoms for patients as well. And then lastly, one that's probably underrepresented and underdiagnosed is an element of depression. Most patients end up developing some changes in their mood after a stroke. Now, some of that's going to be because they suffered a significant physical disability and they feel like they're not the same person anymore. But the growing evidence is actually also suggesting that just the physiological damage that has occurred to the brain changes the amount of serotonin in our brain and can result in depression like symptoms. So we do quite a lot of depression screening for our patients, particularly in our secondary stroke clinic, to make sure that the mood is stable, that patients are not suffering from undue injury as a consequence of their stroke, not just from a physical perspective, but from their neurocognitive and mood perspective.
Wow, thank you so much for that answer to the both of you. We do have another question in the chat box. What are the EMS criteria to direct a patient to London versus St. Thomas?
So that's a very good question. The EMS use, and Libbie, you can correct me on this, I want to say it's the LA stroke scale mechanism, which essentially looks at the severity of the stroke. If a stroke appears to be very severe, that's one criteria. And the other most important part is the timeline from last seen normal. So we very much need to know when the last time that somebody else had or you thought that you were completely normal. Most of the time we want this corroborated with another person. So if somebody had been last seen normal the previous day, and all of a sudden they're now coming in and waking up in the morning with new stroke symptoms, depending on the severity of the stroke, they may or may not be diverted over to London for acute therapies. The timeline for our thrombolysis is about 6 hours for most strokes, and the timeline for endovascular therapy is a little bit more extended and can be up to 24 hours for certain types of strokes. But it's very important. EMS will look at that short time window, the 6 hour mark. If it's within that, they will typically redirect over to London. If it's beyond that 6 hour window, then they'll typically be redirected over to St. Thomas. We'll do our initial CAT scans with contrast to take a look at the blood vessels. And based on that, if the severity of stroke is intense, we may redirect them back up to London if necessary. Although that doesn't happen all too frequently, because most of the time these are big strokes that require endovascular therapy, and EMS will automatically divert them.
Thank you so much, Dr. Cieslak.
Anything to add there, Libbie?
No, that was well covered. Just to add one thing though, I think that really reiterates the importance of calling 911, because as Dr. Cieslak mentioned, if you are in that 0 to 6 hour window and the EMS providers have done their assessment and they can get you somewhere where they know you're going to get that type of treatment, then they know to redirect you there. So just that importance, but really well said.
I do have one last question. I think, Libbie, I know you touched on the kinds of resources that people have access to once they leave and go out into the community. What kinds of plans are in place, or do you mind kind of expanding on that?
Yeah, great question, Kenzie. So anytime a patient is nearing discharge, there's a lot of conversation that takes place before they go. So we usually set up, we call them transitional meetings, where the family, the caregiver, and anybody that's going to be involved when the patient goes home comes onto the unit, and we meet as a group with the team to figure out what are some challenges, what are the barriers, and what do you need from us to feel safe going home. So once we've established that meeting, we kind of get a better understanding of what are the specific supports that this specific patient and their family are going to benefit from. We have our on-site case coordinator through the LIN that comes to all of our morning rounds and collaborates with us. So the case coordinator is very, very large in making sure that anything that needs to be set up is set up prior to the patient going home. And then, of course, providing we've got lots of pamphlets, education, and then follow up in the secondary stroke prevention clinic is huge. So patients get that referral sent off so that we know they're going to be having a follow-up appointment once they've been discharged.
Amazing. Thank you so much. And again, anyone, please feel free, any last minute questions. We do have lots of positive comments in the chat box, thanking the both of you for such an informative and engaging presentation, and just thanking you both for being at STEGH and serving our patients in our community. So if no one else has any further questions, I'll close this out. So Libbie and Dr. Cieslak, thank you for sharing your knowledge and expertise with us this morning. Your presentation was very engaging and was a perfect way to recognize Stroke Awareness Month. And thank you also to our donors for helping make the recent updates to the Independent Living Suite possible, so patients can, like Libbie said, learn new skills before they go home. If any viewers have any comments, questions, or general feedback, please feel free to email us at info@steghfoundation.ca. We will follow up with you with a link to the recording, and please feel free to share it with your family members and friends. STEGH Talks is a series of presentations that the Foundation in partnership with the hospital presents. STEGH's talk sessions will be taking a break throughout July and August, but will be returning back in September. Thanks again for spending an hour of your morning with us and for making a lasting local impact. We wish you a wonderful and safe summer. Goodbye, everyone.
Thank you. Goodbye.
Thank you.